and there was some feedback that some things worked for some people and didn't for others. So next year we're going to look at creating a more bespoke program where it would fit into your role. So if you weren't necessarily managing chronic disease, but you were more doing on the day, there'll be options to go into breakout rooms. So that is most definitely going to be changing the way we look at it next year. So thank you for coming. Thank you for the feedback. We really hope that it was helpful. So as part of the presentation I gave at the conference, we promoted our new non-medical prescribing page, which has been created by the team to support you as learners. With the change to if you are a nurse, the NMC revalidation, it's undergoing a big change at the minute and a consultation process, and you will have to evidence your prescribing in the future rather than just providing reflective evidence. So we wanted to create something that was useful and has a lot of resources on there as prescribers. So I just thought I'd just go through that today. So this is what our support is to you. So if you're not a prescriber, there's information on how to access the prescribing module. Currently, the funds for that are limited, but this may well change in the future, but we'll keep you updated about that. And there is a section on there that if you are a pharmacist, how to access the pharmacist prescribing non-medical prescribing course. If you're a specialist that has a specialist area that you feel you could promote to our workforce and make us safer prescribers, then there's a form that you can fill in that will come through to me. And then there's the events calendar. So if you click on here, I'm not going to do it just in case it crashes because I'm still playing about with dates. You'll be able to see the NMP updates that are planned for the rest of the year. And as soon as I've got speakers booked in, then there'll be a Teams link that you can just join on that day. We've created a NMP update YouTube area where you can access all the old recordings. So if you didn't manage to go to the one in November, which was asthma, you can access that. There's quite a few on there from July all the way through to now. And then there is the knowledge and library services that you can access research articles as well. Obviously, as prescribers, it's not just about prescribing the medication, it's about the ethical and legal considerations. So there's a little bit of blurb on that. And then looking at your reflective practice, the Pieces tool, which is from the My Prescribing website, would help you reflect on how you prescribe and how you prescribe safely. And then we've got our resources. So as I said, the knowledge and library services, how to access the research articles to make sure that you're evidence-based, there's an evidence base to your prescribing, and then access to NICE research. And then safer prescribing, all of the non-medical prescribers should have access to the MPAG bullets, the Tablet Press and Tablet Press Extra. And if you don't get that through on an email, then you can join their mailing list by clicking on here on this tab. The My Prescribing has some pharmacology resources and lots of other helpful tools to help you be a safe prescriber. Everybody that works for the NHS has access to BMJ best practice. So this looks at what's current pathways and has infographics to help you be a better prescriber. Again, NICE, looking at medicines optimization. We've got NICE CKS, which is our Bible in primary care if you're dealing with on the day or chronic illness. And then the BNF. And then we have the specialist pharmacy service. So this is a really helpful service that's got some e-learning built into it, but it also has, you can contact them if somebody has come to you saying, I want to take this supplement, it's over the counter, but I'm taking these medications. And you can ask them for the research evidence for that medication, and they will send that through to you to give to the patient. And then there is an e-learning platform for safe prescribing and evidencing safe prescribing anybody with an nhs.net email can access that. And there is a specific domain for primary care and primary care prescribing. So you can access all of those. Based on the conference on last week, we're going to be adding some tools to help you when you're prescribing. So things like renal calculation tools, frailty tools, so that when you are prescribing, you can access them really easily and make sure that your decision to prescribe is a safe one. So we hope you find it useful. If you have any subjects that you want covering, I would ask that you email me, and that would really help me plan the rest of the year out. And that's it. Thank you very much.
That's amazing. Thanks, Lucinda, especially flying in lastminute.com for me. So that's amazing. Thank you so much.
No
so next up, we have my colleague Claire, who is just going to chat about the new to general practice for a couple of minutes as well. So I'll hand you over to Claire.
Thanks, Mel. Afternoon, everybody. Good to see you. The sun's come out here. There's a bit of sunshine this Wednesday, even though it's cold again. Just a reminder about our new to general practice programme. So this is launching next month. Our first cohort starts next month. So eligible candidates are anybody that's in a new registered role in primary care who started within the last 2 years. So nurse associates, nurses, all of our AHP colleagues, GPs. So anybody with a clinical registration who has started in a primary care role in the last 2 years is eligible to join. Spaces are filling fast. We're really pleased. I'm really excited that so many people have joined already, but we'd love to get as many more of you as we can signed up for this. It's a year-long programme, and basically there's quarterly education sessions. They're very generic, the education. It's around leadership, around being your best self, around quality improvement, so things that are relevant to all. Your practice, it's fully funded, and your practice will be backfilled for your time to attend those education sessions. They're going to be quite sociable as well. We want you to be able to network with your peers across the county, so there's lunch included. And also as part of the programme, we'll offer everybody that joins an external mentor, so they'll have somebody available to them to mentor them outside of the practice for that full 12 months. And we can also offer restorative supervision via our professional advocacy service. Gosh, put my teeth in to say that. We've got a whole web page dedicated to it, which has got the button where you can click to apply. So I just recommend that you have a conversation with your employer first. So obviously a practice manager needs to approve, and then whoever is going to be your kind of internal support as you're starting in a new role. But once you fill the form out, then that triggers a series of emails to those individuals so that we can sort out the finances for them. I'll put the link, and let me just do that now. I'll put the link to our page into the chat so you can click on it, but it'll give you full details of the course there. It's got a downloadable information pack as well if you wanted to have a conversation with your manager about it. And if anybody's got any more questions about it, then obviously feel free to email me, and I'll pop my email in the chat now as well.
That's lovely. Thank you, Claire. I've just had a message in the chat from Lucinda just saying her colleagues can't see the screen. Could somebody just let me know who can and can't see the screen, because that would be really helpful.
Mel, basically what needs to happen is we need to bring each speaker onto the screen. It's one of the new little additions.
Okay. Will you do all of that then, because this is very new to me. Okay.
Well, it's probably a good thing that you missed my face, because I've just been back-to-back meetings this morning. It's probably not a face that anybody wants to see.
Sorry, Claire, you're on the screen.
Oh, gutted you've got to see it.
Oh, thanks, Claire. That's fab. So I know I can see that our next speakers are here. We're due to start in a couple of minutes, so as long as you're happy, I will go ahead. Is that okay, David? Yeah, perfect. Okay, so you would have seen our agenda. It's been a bit of a hot topic recently. So ADHD, we have the lovely David Walton, consultant counselling psychologist, and Gaynor Kelly, who's our specialist senior occupation therapist. Hope I said all of that right. and I will pass over to them.
Thank you. We may also have my other colleague Jason joining if you can manage to jump on the link.
Okay, perfect.
And he's currently one of three, myself being included, psychologists within the team. Okay. The team sadly has diminished. Okay, so normally I can search for content.
David,
when I want to share screen.
What's their your colleague's full name? I'll send him an invite quickly.
Okay, it's Jason Codner, Codnor, or Codner, NER. Sorry. Thank you. Okay.
Yeah, got him.
Is that actually my slide showing?
Yes, I can see them. You've obviously got the side, you've got the next slide, but I'm guessing you're going to
so
if you go into presenter mode.
Yeah.
Yeah, I was trying to actually it's slightly different from what we're normally using. Hang on a sec.
If it's any consolation, this format's new to me as well.
Yeah, it's different to if I put it over to the same screen as the because I've got two screens going.
Okay.
And that might be better. Let's try that one. I've got presenter mobile actually.
There we go.
Is
that better?
Yeah.
Perfect.
Cool. So because I've got side-by-side screens, I may be looking to the left a bit. I probably don't need to actually. Okay, so just to introduce myself, and I'll let Gaynor introduce herself as well. So I'm the current consultant counselling psychologist for the adult ADHD, autism and Tourette's team. If there are people who have been in the trust for a long time, they may have known us in a slightly different guise. So the team started in 2004 as the transition and liaison team, and then it became the adult ADHD and autism and Asperger's team. And then a few years back, we decided that we would reconsider that in light of the term Asperger's no longer being a formal diagnostic term, 2013. And after much discussion, actually, no, sorry, that was 2022. After much discussion, we decided to include Tourette's in the title as well, because it's something the team has perhaps in the past a bit more quietly managed as well. We have very few referrals for Tourette's, so our primary kind of areas are autism and ADHD being the biggest referral source we're currently getting. So I've been in the team for 13 years, and the team has sort of changed a lot in that time. And I'm currently the lead for the team. I've had a sort of background in varied mental health and learning disabilities and different areas, but always had a strong interest in neurodevelopmental conditions. That's my colleague Jason, just arrived as well. From here on in, I will refer to neurodevelopmental as ND, because continually saying the long term tends to sort of make me stumble over the words. So I'll talk ND and I'll talk ADHD and ASD. But we're not going to talk much about ASD today. So Gaynor, would you like to introduce yourself?
Hi, yeah, I'm Gaynor. I'm specialist occupational therapist with the team. I sort of generally lead on the follow-up for autism, but also work across ADHD and autism as well, and just here to support David today.
And Jason? No sound. Can't hear you, Jason. No. Do you want me to introduce you, Jason? Yeah, so Jason's been in the team for 9 years. He's a clinical psychologist, principal clinical psychologist, and sort of similar roles, primarily diagnostic, but also some treatment work as well. Okay, so a brief rundown of what we're going to sort of look into today. The focus is on ADHD, but obviously we are an ASD service as well as the Tourette's, and Jason actually is the lead for Tourette's. And these are the kind of areas we're going to look at. So what is ADHD? What are the kind of impairment aspects around this? So how does it present? Also, what are the differential considerations? Because when we're thinking about ADHD or any kind of ND condition, they're conditions of exclusion. So we have to very carefully make sure we're not seeing something else. It's the most important thing. When you look on all these TikTok videos, they talk about a few symptoms. They very rarely ever mention anything about other conditions being similar to that. So that's really important. I'm going to touch on the screening tools, basic screening tools we would expect someone to initially complete. So if people are coming in from the GP pathway, which is about 80% of our referrals come in from through GPs, then a couple of screening questionnaires are really helpful. I think it's about 4 that we ask people to do, looking at current features of possible autism, ADHD, childhood features of ADHD, and then impairment aspects as well, because just having traits is one thing. People sadly need to be struggling with that, and also the kind of referral side of things. So this is a graph of how our referrals have progressed since the team began. I started in 2012. We were getting just under 50, about 45 referrals a month in 2012. But we started off when the team was not known by anyone, getting about 10 referrals a month. Oh, don't know what happened there. Why is my, sorry, about 10,000 referrals a month. That's just giving you a look at what's going to be happening next. So till the pandemic, where we were getting just over 100 referrals a month, about 105. And then, as we all know, when the pandemic hit, the referrals just shot up and looked like a pandemic graph. And it's sort of continued there. I think most recent figures, and we've been having some work looking at our referral numbers and our data management through System 1. And I believe that most of you guys, sorry, I don't know what's happening here. It's rolling on automatically. Don't know why. Yes, maybe it's wanting me to speed up. That the referrals have possibly reduced slightly, but still roughly 250 plus a month. And most of those referrals are ADHD currently. These are the people that will get a diagnosis. So people who need to have significant difficulties. Some people, and there's a large proportion of people, will never get a diagnosis. Some of those people will manage their features, others don't manage them as well. And I think in the world of ADHD, there are a lot of people in the prison system, particularly men, who are undiagnosed, untreated with ADHD, quite a high percentage. And some will get other diagnoses. So there are lots of comorbid issues that sit alongside ADHD. So we look at ADHD, probably all familiar, some degree with the DSM-5 criteria. We tend to look at this criteria more than the ICD-11 because it's a bit clearer. There are 18 symptoms that we look at in terms of ADHD, 9 inattentive, 9 hyperactivity and impulsivity. And we need to sort of see the progression of that, because ND conditions are lifelong conditions, so we expect them to be across the person's life. To meet a diagnosis of ADHD, children need to have about 6 or more inattention features and about 6 or more hyperactivity and impulsivity features, and adults slightly less, 5 and 5. You can get a diagnosis, obviously, where inattention features meet the criteria, but hyperactivity and impulsivity features are below the criteria, and this is where we have an inattentive presentation, or what used to be called ADD. There is a very rare condition, which is the hyperactivity impulsivity presentation. I've seen less than one hand of people. I've done about 1,400 diagnostic assessments in my time. This is a visual representation of the criteria. As I was saying, when we look at social media, what they tend to talk about is some symptoms. Often they're not clinical symptoms, they're related symptoms. But if they're clinical symptoms, then these are the symptoms, how they're sort of laid out. So we show this picture to people when we give them a diagnosis or don't, to explain. But there are 5 criterion, and it's really important that the other 4 are represented, that is present in childhood before the age of 12, present in more than one setting of life. It significantly interferes with or reduces functioning in those areas, and it's not better explained, criterion E, by something else. So there's times when we won't assess people because they're heavily using substances, they've had a recent traumatic episode, they're currently undergoing a major psychotic episode, and in those situations it's not indicated to assess because it's likely you're going to see something that might not be the usual presentation of that person. So this is just sort of highlighting it again. So these are the inattentive features, inattentive symptoms. So for an adult over 17, like I said, 5 or more. It says for more than 6 months, but we're expecting them to have been present throughout their life generally, but they can sort of ebb and flow and become more of an issue at certain times. Certainly when people are in education, it's more likely that those things will impact on them. So lack of attention to detail, difficulty maintaining attention, not listening when people are speaking directly or giving information, not following through on tasks, so might start things, not finish. The people that might start the decorating job and then leave them half finished, and have lots of jobs like that. Difficulty organising things, difficulty staying with tasks that require sustained mental effort, frequently losing things, often being distracted. Those kind of kids often distracting others as well in school, and very forgetful as well. So it's not a case of having a bad memory as such, so not able to remember things in the past. It's less likely, more likely that something being said or something they need to do now is not easy to remember. So these are some of the clients that might well not turn up for appointments, which obviously is very frustrating for any of us. The hyperactivity and impulsivity symptoms. So the tendency to be fidgety, this is what we often think about when we think about ADHD, people that can't sit still, get up instead of staying seated for longer periods, very easily bored and restless. This is where kids are running around the room and just being very challenging. Difficulties coping with silence, so you'll be in a conversation with someone and they'll be interrupting you, they'll be talking in the spaces, they'll be making noise, being constantly on the go, a bit like the Duracell bunny. Talking lots. Many of our clients, when you're doing a very typical ADHD assessment, because it's hard to get a word in edgeways, although what I've found is people that constantly talk don't tend to mind being interrupted because it's what they're used to. The impulsivity symptoms that are on the criteria are completing sentences, so you're sort of saying something and they're jumping in and saying the final bit, or they're answering a question before you finished asking it. Difficulty waiting, so those people who struggle in waiting rooms, struggle in queues, struggle in traffic, and they might have to take the long cut, the long way around to keep moving. Often interrupting and intruding, butting into conversations, and having that strong need to do that. But when do we count a symptom? So that's the really key thing, because all of the symptoms are traits that everyone has. Everyone has interrupted at some point. Everyone has lost something at some point. Everyone has forgotten something at some point. But when can we count it as a symptom? So this is a triangle that the ex-head of the service, some of you may be familiar with, Quebus van Rensburg, created. So first thing we look at is our observations. Do we see it in the room? Do we see the fidgetiness they say they do? Do we see the talkativeness? Do we see the expressiveness and the way that they behave? Do we hear it? So do we hear the language? For example, when somebody interrupts, the most common thing that someone with ADHD will say is, I have to say it because if I don't say it, I forget it. So it's not because they're rude, it's because they cannot leave it because it'll be gone. We need good personal examples. So when we ask people, why do you think you do these things? And they say, oh, I don't really know. It's really hard to get a gauge of whether that is a typical explanation for ADHD if someone has difficulty justifying things and explaining things. And then the final thing that is really key in our assessments, whenever we can get it, with adults it's not always perfect, is collateral information. So comments and information from teachers, parents, siblings, partners, friends. So we can't always get parental information because some of our clients, I've assessed an 81-year-old woman for ADHD. And I don't think I diagnosed her, but I've diagnosed a 78-year-old man with the most typical ADHD that I get to see. And he obviously didn't have any parent information, sadly didn't have any school reports, but he did have his friend came along and in addition to the fact that I was seeing it all, I was hearing it all, examples were brilliant. His friend also was backing all this up as well. So that really helps us. There are lots of associated symptoms with ADHD. So ceaseless mental activity, constantly thinking, can't sort of stop the noise in the brain. Mood lability as well, emotional dysregulation, very low tolerance to frustration, low self-esteem, variable performance, good in some areas, good on some days, but not on others. And not living up to potential is very, very common. I think some of the ADHD clients are some of the people that are very challenging to work with if we haven't taken into account the ADHD, because they do lots of things that are frustrating for others. But what drives it all, theories kind of suggest that the driving factor, the cog inside the machine, is the inattention. That people are hyperactive because they struggle to focus and their minds need to be active. People are impulsive because the inattention means that they are sort of jumping forwards and needing to do things now. So that's the kind of driving force behind everything. So what's typical of ADHD? We hear these sort of things constantly. People who very rarely or never read a book start to finish. They might forget what they've read. They might be distracted. They might forget they were reading the book and then realize later, oh, crikey, especially with Kindles and things, they might have a load of books they started and never finished. They'll always try to find a shortcut, try to get round things, keep moving when they're in traffic. They'd rather, like I said, take the long cut rather than just sit there. And they need to be productive almost all of the time. They can't really do nothing. And if you ask people, can you just chill out and do nothing? And they say, yeah, I can. But you ask what that is, and often it's, well, I'm scrolling on TikTok. I'm watching something and doing something at the same time. They're still active, and when they're not doing anything, their brain becomes the distractor, the thing that keeps going. People with ADHD generally do not like silence, so they'll have background noise. They may not be really noisy, and it's interesting that people with ADHD frequently like being in nature. And one of the very common interest activities for some men with ADHD is fishing, which seems like a very quiet and sort of sedentary activity, but it's not. It's A, they're in nature, it's very busy and there's lots going on. And B, they're constantly, have you ever seen a fisherman just sitting there holding a rod like a gnome in a back garden? No, they're constantly moving, constantly doing things, putting the bait on, changing the rods. It's continuous. Postponing and delay things unless they're really interested. So putting things off, those forms, those things they need to get back to the doctor, whatever it may be. Forgetting to pay parking tickets until the absolute last minute, or forgetting at all. Constantly needing to say what's on their mind, like I said earlier, otherwise it's lost, it's forgotten. So when we look at the diagnosis, there were ideas before that people would grow out of ADHD. But research suggests that anything from 15 to 80% of people with ADHD still have those traits at a diagnostic level in adulthood. It was considered a childhood condition, but now we realise that ADHD doesn't go away. Some people manage it better, and I think that studies on average kind of suggest that about a third of people may not still still present with ADHD as an adult, but it's probably more so they have the traits that are just not as significant. They're managing them better. The hyperactivity does tend to decrease in adults, so it's not that common to see highly fidgety people, but there will be fidgetiness and there will be fidgety and on-the-go brains as well. But the inattention remains. That remains a factor that we don't see, so we may not see this. People don't get recognised for this. People don't get diagnosed for this. They get misdiagnosed for other things. Some of our clients will say, I've been trying on loads of antidepressants, but none of them have worked, because it's not that, it's not depression. And we often see people where they've come into contact with ADHD because they've been looking for another reason. So they've been referred because their child's been diagnosed, their friend's child, their friend's been diagnosed. And then in the pandemic, social media blew up. So everyone was aware of ADHD pretty much. Hence why referrals quadrupled for ADHD. So in adolescence and in younger childhood as well, the ADHD features can appear fairly normal. We do have people saying, you know, my 4-year-old's constantly running around and, you know, is full of energy. But generally, we need to watch and wait and see how that progresses in school, because there's a lot of young kids that are on the go. But when they get into school and they start to sort of follow those routines, in most people that settles down. But if it's not persistent and very significant, extreme, then it could be ADHD. So the adolescents with ADHD, they have much more difficulty staying focused. They're much more easily distracted and bored. And they're much more impulsive than their peers. So those behaviours will stand above. And if they're not standing above, they're possibly just typical behaviours. And sadly, they are far more likely to fail academically. The education system is designed for the average, where people kind of fall. And if someone is academic, they'll fit in well and they'll do well. If someone manages to cope, they'll probably do okay. But if they have these kind of difficulties, they're far more likely to fail. Far more likely to have serious injuries by their reckless behaviours, more likely to drop out of school, be expelled, far more likely to be suspended. So if you're speaking to someone that could have ADHD, these are the kind of things that they might say. I have to interrupt, I have to say things, otherwise it's gone. I can't cope with silence. I have to be doing something. Like I said earlier, I have to take the long way around. And people with ADHD, these features are not just from time to time, they're pretty consistent. There are times when people will talk about hyper-focusing, but they're fewer and far between than the general, which is this constant inability to focus. Not fully mastering things and not giving it the time, not being able to stay with things to actually get things done and to develop a mastery over things. And because of that, and because they're constantly told, stop doing that, that's not okay, that's not the way you should behave, etc., it severely impacts on their self-esteem. And there's a term that's come up, it's not diagnostic, but it does have relevance, which is rejection sensitivity dysphoria, where people with ADHD, and I'd say this relates to autism as well, go through a life of being told that what they're doing is not okay, that they shouldn't be behaving in that way. So they're often criticised for long periods until these issues are recognised. In the school, there are lots of difficulties. So people finding it very hard to self-regulate their emotions, etc. People with difficulties managing their attention to paperwork. There are very common subjects in school that people with ADHD tend to like and not like. So they're far more likely to enjoy the practical subjects, the hands-on subjects, the spoken subjects, the doing subjects, far less likely to enjoy the subjects that are more requiring attention and writing and lots of reading. So they'll have difficulty staying alert and focused in class. Their organisation, their planning will be bad, so more likely to not bring the equipment into school, more likely to forget things, forget homework, not manage homework, do it on the bus in on the way to school. One of my clients was very lucky, saying the other day that he had a friend and their form tutor, their form room was in the IT department, and she would do his homework before tutorial on the computer in the tutorial in the registration room, which is dead handy. Wish I'd had that. Procrastination, not getting down to the things they should be doing things that are more interesting, that are more stimulating. Very poor time management. Those patients that turn up late to appointments frequently miss their appointments, forget to attend. And this general sense of restlessness, so the way that people feel inside. So this is a flow chart to sort of look at what the difference of an assessment and the process can be. So these are the kind of things that people experience: the poor concentration, the disorganization, the distractibility, forgetfulness, fidgetiness, restlessness, being on the go, being talkative, impulsive, and interrupting. This causes people a lot of frustrations and those around them. Over time, when that's consistently impacting and they're consistently being told these things aren't okay, it can affect their mood, their behavior. It can then affect their self-esteem, self-blame, and people often turn to poor, unhealthy coping strategies to manage this. This could impact on their social life and also their occupational future, health future as well. Sadly, there's a lot of people with ADHD who turn to substances, alcohol as well sometimes. It's most commonly cannabis and stimulant, illicit substances. Cannabis is probably the number one though. But an ADHD diagnosis can give a person access to medication, to psychoeducation, psychosocial support, to exercise and diet strategies and other strategies, to a support network. Finding the right job. We see a lot of people who are actually doing quite well in jobs, normally because they're ones they're either passionate about or they're ones that fit with their ways of being, often physical jobs, doing jobs, creative jobs. And ones where people manage the best is when they're able to dictate their hours, or dictate the way that they work, self-manage. That can often work well. People who run their own businesses, if they can manage the paperwork side. So finding the right job is really, really key. CBT, coaching, and general kind of psychosocial support. The NICE guidance talks about environmental modifications, so people doing things differently, using different strategies and managing it. And then this leads to potentially the best possible outcomes: personal, social, occupation, and health. Russell Barkley, he's described that ADHD is not a disorder of knowing what to do, but one of doing what one knows. So people with ADHD know what they should be doing, but they just find it really hard to make that happen because the ADHD, the way that the brain works, just gets in the way. And in school and different situations, they're frequently told they need to try harder, they're not achieving their potential, they're motivated or bothered. And in school reports, which is one of the really fascinating sources of information that we have access to, we're frequently reading being disruptive. If only they would listen, they could achieve so much better. Forgetting things in school, being disorganized, making careless mistakes, not checking their work afterwards, presentation of work, lots of different things like that just keep coming up for us. Talkative in class, having to be separated from their friends. We've often got to think about women as well, because women and girls with ADHD can often present quite differently. So we need to take that into account. And there is sort of a higher incidence of more sort of mood disorders, and people struggling managing emotions, and those kind of behavioural things, depression, more commonly. There was went to, I think it was a Takeda, a drug company presentation, and they showed these sort of what stereotypical images of young people with ADHD, and the little boy was standing on a hillside and doing a star jump with his arms and legs outstretched, looking very energetic. And then the little girl with ADHD was sitting in the corner, back against the wall, head in her hands. So that's the way they were kind of depicting, and there's something in that. But it is the case that we see stereotypical ADHD in girls as well, or women as well. It just depends on the individual. So the impact on people's lives. So in terms of the activation side, so this is thinking about executive functioning. Trouble getting started on work and organising tasks, misunderstanding the directions, so not listening to the instructions properly, not knowing what needs to be done. In terms of focus, so losing focus when trying to listen or plan, forgetting what the person's read, need to reread that. Issues with effort as well, so sleep regulation. It's not a diagnostic criteria symptom, but it is very common in people with ADHD. In fact, very few people with ADHD do not have sleep problems. Can happen, but it's rare. Quickly losing interest and difficulty getting things done on time. Emotionally, the emotions impact too much on the thoughts and actions, and people can't just put things to the back of their mind so easily. Thoughts can be quite impulsive as well. Memory is very common for people to forget to do things in the future, prospective memory. Very difficult remembering things that have been taught and learned. Losing track of papers, not knowing where the notes and things are. And then in terms of people's behaviours and their action, people do things too quickly. They're not careful. They make careless mistakes, and they might have difficulty adjusting to the different settings that they're in to know how to sort of manage those. In terms of differential diagnoses, so these are a list of conditions that we have to either rule in as additional to ADHD or rule out as being not the cause of the issues the person's come for. Because when someone's highly anxious, it's going to impact on their ability to remember things. It's going to impact on lots of things. So anxiety will have people have ceaseless thoughts and avoidant behavior. In depression, there are also unstable mood issues, impatience, irritability, insomnia for some people during those episodes, although some people can sleep too much, and low self-esteem. So very similar kind of characteristics. We do see people with personality disorders, sometimes with ADHD, sometimes instead of. So antisocial, borderline personality issues, emotionally unstable. People will have poor social interactions that we see, impulsivity, tendency to take risks, adult instability, tendency to sort of have emotional focus on things, but you will see more feelings of emptiness and abandonment than in typical ADHD. Hypomania and bipolar 2 disorder and cyclothymia. This is differentiated by the grandiosity of things. It's a clear focus of the thoughts, but it also has a reduced need for sleep. Psychosis can be present as well. The traits are not normally as consistent in mood disorders, so more episodic than we see in ADHD. It's quite common so bipolar 2 disorders quite often can be confused with ADHD because the mood states change quite rapidly, like in ADHD. But typically in ADHD, the mood states can change for no obvious reason. They can just suddenly flip from one thing to another and then back again quite quickly. Oppositional defiant disorder. So it's common to see young children, young boys particularly, with this kind of behaviour. Sometimes ADHD can be another factor. Sometimes it's ODD stands on its own. So there's lots of defiant, hostile behaviours. But the behaviours tend to be deliberate and willful. In ADHD, it's not normally. So Russell Barkley sort of was saying that it's problems starting of tasks, this act of defiance, to follow rules, to be cooperative, people losing their temper quickly, being very quick to anger. So lots of conflict in the ODD presentation. But there are studies to suggest that people with ODD can also benefit from medication if it's relevant for them. This next term is not a diagnostic term. This comes from Stephen Biddulph in his book Raising Boys. To anyone who's got young boys, it's not a bad book to read. There's a Raising Girls as well. So he talks about the concept of if dad is not present or is not a positive impact on the child, this lack of adequate parenting can lead to lots of difficulties that could be presenting as ADHD. But if you look across that child's lifespan, it's only if that continues that it could be ADHD, and it's likely that it may not. It could just be because parenting is not positive and a not helpful influence on that child. When we look at some of the differences, we're not going to go into this today, but this is one of the examples of a difference between ADHD and autism. So in ADHD, people scan the environment and struggle to delay. They want to sort of find the most helpful, interesting things and just ignore the rest. In autism, Asperger's type presentations, people record everything. They struggle to filter, and this can be one of the reasons why people with autism become so stressed, because they tend to process all the information and take it all on board. And if they're quite calm and the situation's not too stressful, that can be okay. But if the situation's stressful, it's busy, it's loud, there's lots of people, then that can cause them to feel a sense of overload on a sensory or other level. And it's hard for them to just focus on what is most important in those situations. One thing that's become very apparent to any of us that have done ND assessments for a long time is that there's an expectation of how it's going to feel when somebody gets a diagnosis. I'm really conscious of this more and more, that we're one of the few services in the mental health type world where people actually want to be confirmed with a diagnosis. People don't go to CMHTs and want a diagnosis of psychosis. They don't want a diagnosis of depression or personality disorder or eating disorder, but pretty much 90+% of our clients want to be diagnosed. They come for that diagnosis and they're expecting a sense of relief and positivity when they get that diagnosis, if they do. But interestingly, there's a diagram called the Fisher Personal Transition Curve, which kind of highlights this, that when people get a diagnosis, sometimes there's quite negative emotional responses. Some people feel anger because they weren't diagnosed earlier, because they were mistreated, because they weren't accepted or understood. Sometimes they feel a sense of sadness for all these missed opportunities. So they need to work through that pretty much like a grief experience, to go through that process and kind of understand what it is for them, what ADHD or autism means for them in their life, and how they can make sense of things and learn to connect with their true, authentic selves. So they need to kind of integrate this information and to plan for the future. So if you're referring to us, then it's important to identify the kind of diagnostic markers for these. The impairment is really vital as well. So a lot of people will connect with these conditions, but how much it impacts on their lives depends on how much an assessment is needed. And because of, as you saw at the beginning, because of the massively increased levels of referrals, people are going to have very, very long waits. Currently within the service, we're seeing people who were referred nearly 4 years ago, but that was when referrals were 105 a month, and they're 3 times that. And that was when we sadly had, well, not sad then, but now, we had a much bigger team. So, you know, we're not able to get through the people that we used to. So initially, we like people to complete some screening tools. So the AQ10 is a cut down version of the autism quotient, as created by the Cambridge Lifespan service, Simon Baron Cohen service. It says AQ10 with explanation. So when someone says they struggle with small talk, it's good if they justify that with why and how and when and how much, not just say small talk's hard, because it doesn't give us much information. And then the ASRS, which is the autism symptom checklist, again with explanations, and only often or very often scores are relevant, even though it was designed to say that 7 of the 18 symptoms at sometimes is relevant. That doesn't seem to fit, because if you sometimes lose things, that's everyone, isn't it? Pretty much. You know, okay, some people are more rarely, but we all do these things. So people justifying the symptoms that they think they have. So when you're considering referring, is this relevant? It's also important that the client is really invested in the process. We always ask people 2 main questions. Why are you coming for this assessment? What are the reasons that you want to explore this, and why now? And then the second question is, what do you hope to get out of it? You know, if you give it a diagnosis, what difference will that mean to you? So a justification of that referral. We're happy to consult where we can when there's uncertainties. This is the ADHD. So as you can see, there's the ASRS questionnaire. Like I was saying, these 7 items here are the sometimes, but it kind of strikes me that forgetting obligations and appointments sometimes is not uncommon, whereas doing it often and very often. And how often is often? You know, if you crash your car often, it could be every 3 years. If you lose your keys often, it's got to be every week, or, you know, pretty frequent. But when people put often or often, we want them to justify what that's about, not just to say, I forget things. If they forget things, then then what do they forget? Do they forget appointments? You know, specific things. It's good to know that detail. If it's possible, I know it's not always possible time-wise, it's good to go through the forms with a client. I was talking to Dr. James Finley, who some of you may know, and he said that when he was working as a GP, he would often have several meetings with a person where ADHD or something was raised, and he would build up an idea if that was relevant or not. I know this is not always relevant, not always possible, sorry. But going through the forms can get a richer amount of information if it's possible to do. The way they answer. So the forms aren't brilliant, you know, they're just a tool. They do not diagnose. So we need to sort of look at it. And like I say, how often is often. So we don't expect tons of information to come in, but we just, if we can get it, we'd really like people to say, these are the reasons why the person thinks it's relevant. Good reasons. These are the reasons why it's significantly impacting on them, and how it kind of links to those things. And then why now? Why is it that they've considered this now? As I say, the waiting times across the UK, and I imagine across the world, are huge. some trusts are publishing figures of more than 10-year waits. NHFT is for whatever reason, the recent FOI wasn't able to produce any results, but our service would be looking at those kind of weights as well. But we can't quantify. We don't know for definite what it would be. Okay, is there anything, Gaynor or Jason, anything you wanted to add to any of them?
Just that also people can be referred if they've already had the diagnosis for follow-up.
Of course. Yes, thank you.
Yeah, just mentioned that. Yeah.
Yeah, and it's worth pointing out that the team is quite large. I think we have about 27 team members, and most of those people are primarily focused on treatment. So we have a number of occupational therapists like Gaynor, and nurses and support workers, and psychology is sadly only a couple of qualified psychologists, but we have a number of assistant psychologists who assist into the process of treatment and screening process. And part of our service is also the prescribing of medication. So our non-medical prescribers, our nurses, they handle something like, is it 80% or 90%? But it's most of the prescribing for NHFT clients across the trust. Sadly, the waiting list for them, because of the demand, and we're getting a lot more private pathway assessments coming in, which is bringing another dilemma, that we have to look to the quality of these assessments. Our assessments are not quick, because guidance and liaising with other diagnosticians across the country would suggest that each assessment has to take several hours. Because if you're going to run a checklist of what could be possible ADHD or could be possible autism, that's one thing. But if you're going to then corroborate it with further information, look at differential considerations, look at the wider kind of factor to see if that is the right diagnosis, because it's a big deal giving a diagnosis, and we don't want to give it to just anyone. And particularly with ADHD, there's the medication to consider as well. So we take our time. the UK Adult ADHD Network, in relation to adult ADHD assessments, has published a paper called the AQAS. They published that last year, and no, year before. And we're basically saying that 2.5 hours needs to happen for an ADHD assessment to be done comprehensively enough. And as we're all, well, most of us would be aware, there's a lot of private companies trying to do ADHD assessments in a very, very quick time. In cases where that person is more obvious, then they'll probably get the right outcome. But I've come across a number in my time where someone has been diagnosed through one of those online brief assessments, and it wasn't the best diagnosis for them. So we have to be very careful with this. Okay. So that's all of the slides that I've brought to go through. And just wondering.
There's a lot of questions, so it's in the Q&A part, so it's whether you want to work through them as a team or me to shout anything out. Just let me know if you can see them.
I can see them now. So non-medicinal guidance, right, resources prior to diagnosis. Yeah, I mean, there's a lot of online information. There's yeah, I mean, there's lots of online services. One of the ones that we often recommend is the Attitude website. So the ADD Etude, which is an American online magazine, but it has a lot of really helpful information. And there's services like Addis, and you can. We are trying to sort of put things in place to support people. Our website has signposting on it. So we would recommend people look to those kind of areas. Anything, Gaynor, you'd recommend, or Jason? I don't know if you can speak.
I was going to say our website. If you check our website out, that has quite a lot of resources and signposting as well.
There are also ADHD coaches out there. In this country, they're not particularly regulated, so there's probably much better ones and not so good ones. So you've got to be a bit careful on that. They're more regulated in the US. Right to choose pathways, that's an interesting one, because that obviously is something that GPs will actually be making the decisions on. As far as I'm aware, the trust, the ICB, is not currently funding that many right to choose assessments in our trust. In other trusts, there's far more. But it's down to those sort of funding that as to whether that's something that we considered. We do have people that come through the right to choose pathway. We then need to sort of look at them for treatment, and as someone said, can they be referred to our team? Certainly can, for medication and support. The waiting list currently for our NMPs for medication is probably about 16 months, which is awful, purely because of the numbers. And with more private assessments happening, there are more people that are diagnosed. How long is a referral for help once diagnosed elsewhere? Similar, really. I mean, we have an autism and an ADHD advice services, so one for each side. These are what our treatment team offer. So gainers, OT colleagues, and support workers run the autism advice service, and the ADHD advice service is similar and offers some webinars and also some individual work, as well as recommendations for reading and websites and things. So we have those kind of those options. When it comes to personality conditions, if someone is found not to have ADHD, we'd refer them to the PD hub. That would probably be their pathway. But the PD hub only accepts people who are under under another team. The key worked under another team. So they can access a thing called the You and Me group. They need to be referred for that. And if we don't diagnose somebody, we can refer them to that group if that's more appropriate for them. There's no service in trust currently for some of the more complex PD conditions like antisocial PD, sadly. Children are failing a GCSE level due to ADHD. I think I've addressed the sort of the time frame. Incredibly long, basically, very, very long. It's not acceptable. It's not what we want to do. We can't prioritise anymore because the referrals are just far outweighing what we can offer. I can share the slides, yeah. Inattentive ADHD can be not always difficult to manage or treat. The medication can have a positive effect as well as other sort of psychosocial changes. It can be more complex to identify depending on the presentation. In terms of the slide sharing, I'll share them with Melanie, and then she can disseminate them if that's okay. Masking in ADHD does happen. It's obviously difficult to mask all the time. It's like in autism as well. If people mask to the point that they don't actually present any difficulties, then is it ADHD or autism? But people certainly can manage better with really good strategies. You can cope with things. So it may not necessarily be masking, it could just be managing using better strategies. Supporting sleep. There are sleep clinics. A referral to a sleep clinic is a good way around, because they will look at person's the sleep routines and explore that well. They wouldn't look to prescribe melatonin or medication for sleep until they've looked at all the kind of structure of things, because if people aren't following a good sleep hygiene, then that needs to be addressed first. But a referral to a sleep clinic, a specialist clinic, would be indicated if sleep hygiene changes are not actually making the impact. Ooh, that might be all.
I think you've had more since you've been talking that's come up to the top. So I think you might need to scroll up now. Trying to think where we got to.
Ah, there we go. New posts. Can GPs be trained to diagnose, rule out? Potentially, yes, absolutely. It's one of the difficulties, though, isn't it? That actually there's oh cracky, I can't remember what it was called now, but there's a GP organisation group that are trying to push this exact thing, and I can't remember what it's called. Do you remember, Jason? Because it was at UCAN. That chap was speaking, and I can't hear you because you're.
Jason, have you tried unmuting yourself, because it looks like you're clear from this end?
No, something. You might want to log out and log back in, Jason. That might work. Yeah, it's worth if you contact UCAN. So contact UCAN and ask them, because there is a GP organisation that was set up to look into this. Because obviously, GPs generally, you guys have a really short amount of time to see people. So the thought of doing a 2.5-hour assessment, or a much longer assessment, I don't know how that would work, but yeah, no, absolutely. And UCAN does training for ADHD diagnosis, but it's important that that's also supported with a specialist to support and supervise that, because no training will make you an up and running diagnostician. Different clients can present so differently. Oh, I like that. That's a good question. Do we have a list of right to choose organisations which provide the best assessments? I wish we did. NHFT says we're not allowed to actually say what companies. But interestingly, there's various companies that we find tend to do better assessments, but then they don't always, because it's down to the diagnostician. So sometimes they are a bit sort of questionable. It's very hard. What we want to see is comprehensive assessments being done in enough time. People don't always need to be seen in person, but it can often help. And you're absolutely right, Gemma. It is not good enough that we have these issues, and because of the sheer numbers of things that some trusts are looking at only in the NHS, only seeing the most complex clients. The ones with significant other mental health conditions, which is not okay, because there are plenty of people out there who have significant issues, but aren't that severe. I'd say that we shouldn't be seeing anyone that's really mild and really kind of coping with their issues. It's not having a significant impact. Clients cannot directly self-refer, but if a client comes to the GP, we are happy to accept what our old boss used to call a blessed referral, which is basically they give the information, and then a GP just sends it in and said, I'm happy to refer this person, here's their information. We do have referral forms, obviously, so it's about getting a good mix of information that does highlight those common traits of ADHD. The team do ask for a lot of information, purely because the numbers are so massively high. It's very hard for us to move forwards unless we've got clarity. I know it's challenging. I can't imagine what it's like to work in a GP situation where people are coming in so fast and seeing so many people. It's just very hard for specialist services to move forwards with a referral if we can't see a fairly clear picture. And eating many sweets be a form of self-medicating. I've not heard that one. Well, probably not, but it could be. Yeah, it could be a behaviour associated, perhaps. Yeah, sadly we used to prioritise, but that was when we were getting sort of 150 or less referrals a month. But when we sort of hit the really, really high numbers, we were struggling to read them. It would take us a day a week just to read the referrals we were getting. So it's very hard to prioritise now. I think that's okay. New posts are coming. Patients that are referred to us with what seems poor assessments and right to choose, we'll do a diagnostic reconfirmation. Quite often we'll ask the person to try and get the diagnostician from the assessment company to clarify things if we can. So if they are able to provide the additional information. If they're not, it probably reflects the fact that they've done an hour online assessment and haven't had enough information. We wouldn't have the manpower to come into primary care to screen people, sadly. ADHD can run in families, absolutely. There is a large genetic element to ND conditions. So we often see other people in the family with traits and sometimes diagnoses as well. ADHD and autism cross over considerably. So some studies suggest that up to 40% of people with autism might also have ADHD, and up to about 25% of people with ADHD might also have autism. Being able to sort of cope and mask symptoms is common, because as people as they age, they tend to learn better strategies to manage. Not sure of the effect of the government's desire to reduce the benefits bill. I'm sure it's going to have a major impact. A lot of our clients really need the support that they can get, particularly our autistic clients. They often need a lot of support. I think is that all of them? I think that might be everything.
I think so, because I think the top one is a comment as opposed to a question, I think.
The new one there. Is there a link with ADHD and dyslexia? Jason, you can't answer this.
I might be.
We can.
Oh, we can hear you.
Well, yeah. I had to log out, so I lost a lot of questions, I'm afraid, really. Yes is the short answer. Yes, there is a link with ADHD and dyslexia. We don't routinely screen for it as a service. There are some screeners. If you can go to the Dyslexia Association, there's a national charity that I think they've got a screener on there that you can use. It's a bit tricky with adults for the dyslexia bit. They can get an assessment, but they'd have to pay for it privately. Again, the Dyslexia Dyscalculia Association, they have a list of providers, really. If it's child, some schools do have Senkos who are trained to identify dyslexia. As part of that process, sometimes they might do an ADHD screen. Sometimes we've got reports coming from a client who might have had an ADHD diagnosis as a learning difficulty. So an educational psychologist or an education specialist may have done an assessment that's given a learning difficulty diagnosis, so that that child or young person can access support in school, but it's not a medical diagnosis. That means they then can't access NHS support, so they'd have to get a reconfirmation or a full assessment if they were looking to access medication in terms of that. But yeah, there is a link between ADHD and dyslexia. There's I think roughly, giving percentage is always tricky, but 75-ish% of clients who have ADHD are likely to have some other either comorbid difficulty as well, either that's mental health related or another neurodevelopmental condition, really.
I will sort of add to the, unfortunately, one of the things that is a kind of hidden weighting issue is that when people come to us for an ADHD assessment or an autism assessment, it's not uncommon, like I was saying, that because of the crossover, for the other condition to be relevant as well. We will not send people back to their referrer to be re-referred. We will continue and do the assessment. So whereas that first person who gets diagnosed with ADHD and then needs an autism assessment, then they'll stay on our books, but there won't be another referral. So we'll have to take that much longer to see them for the next bit as well. So that can delay things, and that's not something that reflects in our figures, unfortunately. Okay, should we leave it there?
I think there was, I did say we'd answer the last two, but then
Okay.
I'm keen we'll need to move on to the next speaker, if that's okay.
No. Thank you all. Thank you all for listening. Good
That's
luck with your
lovely.
future referrals.
Okay.
Thank you very much. Like I say, we'll send those slides over, and then any contact details or any links to the website you can share with us as well. That'd be fab.
Okay, lovely. Will do.
That's
Thanks,
great.
Alan. Cheers, guys.
Thank you.
So,
Have a good
Take
rest
care.
of the day. Bye.
Bye. Right, we're running a couple of minutes late for starting our next session. So I'm going to hand you over to Angela Abdullah. I hope I'm saying that right. She's the headache specialist nurse and independent prescriber at Northampton General Hospital, and she's going to be talking to us about clinical management of migraines.
Sorry, Melanie. Can you just point me how to get my slides on the screen?
Yes, Craig will be better at this than I will, because we've got a whole
Tech
new
is not my
system
strong
today.
point. Okay.
Hi,
not just me
Angela.
then. Hi.
At the top of your screen, there's a
Yeah.
little ribbon that runs along. You'll see the leave button.
Yeah.
Next to that is a little button that says share.
Yeah.
If you click on that and then choose the screen that your slides are on, it will share that screen.
Oh, well, it says presenter mode whiteboard aren't available during this event.
Yeah, no, you don't need that. It's just purely the screen. If you open up your PowerPoint,
Okay.
it will then find that particular window that's on, and you'll see the start of it. And then you just click on that one and share that particular window.
Okay. Just give me a second.
No problem.
There we go. Okay. Are you getting that or?
Not yet. No. So
Okay.
on that share
Just click
button
on-
and then click on the actual window that the slides are on.
Yeah. Click on share or?
Yeah.
Do you want me to drive your slides?
If you would, that would be
Yeah.
wonderful.
We'll just need to do the Chris Whitty.
All right. Okay. Whatever that is. Yeah. I
Yeah.
remember.
Next slide.
How do I get them to you then? Have you got?
I've got them. They've been sent over to me already.
Okay. Yeah.
So
If you've
Angela,
got them,
Craig
then
will put them up, and then if you just let us know when it's next slide, and we'll move them across. And then people will use the Q&A, which you'll be able to access either at the end or
Yeah.
whatever,
Okay.
however you want to do it.
Okay. So yeah. So a brief whistle stop really about migraine management. Hopefully, some of it will be relevant to GPs. There's a lot happening in headache world at the moment. Pui is not with us. She's defected to Copenhagen. That's my disclaimer. Yeah, next slide. And so these are the learning objectives, just about the burden of migraine, a little bit about diagnosis, a little bit of the understanding about the science of migraine with the new treatments in mind, overview of acute and preventative treatments, and a little bit about the new GPANTs, which are now green on our your ICB pathway, that you might need some info about. Okay, next slide. So that's next slide. Migraine. So just really to say, migraine is a highly prevalent condition. I'm not surprised that it's the third most common health condition in the world. But just the numbers are a bit staggering. To think that 1 in 4 people are living with migraine, predominantly female. It's not surprising that we're quite busy in our department. Okay, next slide. So an individual suffering with migraine, it's the highest cause of global disability in the general population, but first in females 15, it says 49, I normally say 15 to 50. Anyone that thinks it's just a headache really has got no idea. So it's not just a headache, it impacts on every area of life, reducing activities, reducing capability to work, negative effect on relationships. You know, nobody wants to be with someone who's always having to cancel because they're having to retreat to dark rooms and miss events. And the effect that has emotionally on the patients is hugely impactful. Okay, next slide. So a little bit about diagnosis. What do patients experience during a migraine? So with episodic migraine, it's usually a prodrome. Then the cortical spreading, activation of the trigeminal system, altered blood flow, and then the interictal phase is often the most difficult bit of the condition to live with. Next slide. Oh, okay, sorry, that's just clarifying what I was just saying. So yeah, so patients presenting to primary care mostly have migraine. There's been landmark study, all disabling episodic headache with a normal physical examination. 94% will be suffering from migraine. Yeah, so I think most GP clinics will have 1 migraine sufferer per clinic. And from my findings, that generally still patients are not diagnosed and not treated, let's say, appropriately. Okay, next slide. These are screening questions that point you to migraine. They're not really questions that I particularly use. I just ask generally, but they're a good tool just to prove the migraine diagnosis. So, you know, if patients have got 2 of 3 of those symptoms, chances are you're dealing with a migraine sufferer. Okay, next one. Next slide. A little bit about the science. what is it? If you've got the migraine gene pool, then it usually is a lifelong condition. It goes in peaks and troughs, usually in the female population. Puberty, pregnancy, perimenopause are the 3 Ps that generally are the patients that are being referred to our clinic. Attacks can be mild, moderate, very severe. Usually early adulthood is when they start, although there are studies that migraine in children is being identified more commonly, and with some thoughts that if it's diagnosed from childhood, that can help manage the condition throughout life and avoid A&E tendencies, misdiagnosis, lots of investigations, if we know that that is probably what's leading to them being unwell at the time. Yeah, migraine, not just a bad headache. We'll just put that in red again. Next slide. Sorry, next slide. Hello. Sorry. So the migraine brain, it looks normal. MRI scans, the number of times patients just say, can I have another MRI? MRIs are not curative and really done to rule out, to alleviate patients' anxiety and to rule out the very rare finding that there's any other cause. So all of those things can trigger migraine. Some things are more avoidable than others. Stress in the modern world, diet to some degree, our modern world environment is not very migraine friendly, with flat computer screens, black on white, supermarket noise, all of that, car headlights. So it's not surprising that there's more prevalence in migraine. Okay, next slide. So there are some theories about the trigeminal sensory pathways. So the slide is almost self-explanatory. So lots of complaints about orbital pain, often cervicogenic pain. So yeah, it's usually, you know, the pain can vary from attack to attack. It's not usually always confined to one place. Sometimes it is, which makes us think of other headache diagnosis. But generally, if you've got changing pain sites, then most likely you're dealing with migraine. Okay, next slide. So CGRP, the calcitonin gene-related peptide, it's a bit of a buzzword at the moment because the new treatments are CGRP receptor or ligand blockers. We know that CGRP levels rise with the prodrome, and we know that migraine sufferers generally have higher levels of CGRP. When scientists have infused patients with CGRP, it can trigger a migraine not 100%, but we know it's a player in migraine generating substance. Okay, next slide. So the CGRP inhibitors, new medications, originally self-injectables, but there's now the new oral GPANTs that are changing the landscape really of migraine management. Okay, next slide. So I'll give you an overview of prevent treatments. So for acute, NSAIDs really are the go-to. If they're contraindicated or not tolerated, good old paracetamol. If the attacks are more severe, there's still a big need for triptans. And if one triptan is ineffective or not well tolerated, it's always worth trying a second triptan. And triptans in combi with antiemetics, NSAIDs, aspirin, and to combat the migraine as soon as it starts to occur. And then the rimagepant is the new acute treatment, licensed and available now. Preventative treatments, so still the nice criteria for CGRPs and or Botox still is to have the diagnosis and then try at least 3 prevents. They can be propranolol, obviously not if asthmatic, candesartan, amitriptyline we use quite a lot. Because of the female population, topiramate is a bit of a no, although I've still got many patients who rely on topiramate for their prophylaxis. And then the GPANTs now with specialist recommendation are being used for prevent. Okay, next slide. So these are the targeted preventative treatments that you move on to after you've tried and failed those 3 prevents. We're still using Botox and it's still a good treatment, although capacity is bad at the moment. We've got long wait times. The injectables, still many patients I manage with the monoclonal antibodies, be it injectable, self-inject and or the infusion, and rimagepant and atogepant. Over the last couple of years now, we're using more first line as first line prevent trials before moving on to other treatments. Okay. So, sorry, next slide. So we'll talk a little bit about rimagepant. So there was an unmet need, and the GPANTs are filling that need to a degree. So still 80% of patients do respond to triptans, and there's still a great need for them. But there are issues with overuse of triptans. Some patients, if stroke is a contraindication, of course, to triptans, and some patients, triptans just make them feel worse. They suffer breathlessness and just can't tolerate them. So if that's the case, then rimagepant is worth a trial and is proving effective in the patients that I manage. I've got some really good responders to rimagepant. Okay, next slide. So that's the information about prescribing rimagepant. It's a 75 milligram tablet. It is a daily maximum dose, and it is particularly good for menstrual migraine, I'm finding. Yeah, so, but you don't, unlike the triptans, you don't take a second dose if it doesn't work. Okay, next slide. Oh, yeah, not licensed in pregnancy or breastfeeding. None of the GPANTs or CGRPs are. Some interactions with particularly clarithromycin and some of the antifungals, but generally they're tolerated with most medications. Side effect profile is good, usually very well tolerated, with nausea being the main reason for not taking it. And say hypersensitivity, really uncommon. I haven't to date come across anyone that has had a yellow need for yellow card report with rimagepant. Okay, next slide. That's just proving really that the safety of rimagepant compared to a triptan cardiovascularly. It's up to now we haven't found any serious problems with cardiovascular history. Okay, next slide. It's a little one of the studies of rimagepant showing superiority over placebo, measuring the pain freedom. The MBS stands for the most bothersome symptom. So sometimes it's not the pain, it can be brain fog is one, and so it fares well against placebo for pain relief and other symptoms. Okay, next slide. More, that's comparing it to sumatriptan, which the slide really says, there's still good response to triptans, and hence the reason if patients can have triptans, that's our first port of call still. Yeah, patients' lifeline for many migraine sufferers. Okay, next slide. So this is a pain study, and most bothersome symptom study, which yeah, is just proving the treatment success versus rimagepant and placebo. Okay, next slide. Targeted preventative treatments. So Rimagepant is now licensed as a preventer. Those are the indications: at least 4 migraine attacks per month. Generally, I'm dealing with the more chronic sufferers, but we know that if patients are treated when their symptoms are low, when they're more episodic, that they don't go on to need the more chronic treatments. So you know, I think treating early, we now know that there is good benefit cost-wise, patient cost-wise, and should be considered. Okay, next slide. So that's just evidence about the ongoing benefit of using Rimagepant over a 16-month period. And we know that it proves that headache, migraine days, most bothersome symptom days reduce with ongoing treatment. So basically, you know, if you start needing more doses, generally with time, if it works, you need less treatment doses to maintain your migraine management. Okay, next slide. So this is Atogepant, which I've got more experience of, mainly because it was first license for a chronic migraine daily prevent, but it's now being used for episodic as well. Normally advised to take it at night because of the side effect of sleepiness reported in some of the clinical trials. Again, generally well tolerated. The main side effect being constipation. Nausea tends to reduce with subsequent doses, but the somnolence is can be a problem, but less so if the patients take it at night. I found. Okay, next slide. That's the prescribing information. Caution with renal and liver impairment, although most of the migraine population, it's not usually an issue. There are cautions with hypertension. So I'm now asking patients to do a baseline blood pressure and monitor for the first 2 weeks after taking the tablet, and to stop if there's any dramatic increase in blood pressure. Obviously, if they need a course of clarithromycin, they stop the Atogepant for the course. There is a 10 milligram tablet, but it's impossible to get hold of, and by the time they've got it, their infection has passed. Not licensed again in pregnancy or breastfeeding, but because of its short half-life, if I'm worried about patients planning to conceive, then I tend to go for Atogepant rather than a self-inject because of the short half-life. Okay, next slide. Those are the Atogepant clinical trials, or some of them. It's got good results, patients achieving greater than 50% reduction, not just in migraine days, but in the migraine burden. So yeah, it's proving to be a good medication. Okay, next slide. That's the long-term study with atogepant. So again, demonstrating good results with good safety features, and yeah, it's a safe, effective treatment with about a 70% response, positive response rate. Okay, next slide. People ask about conjunctive therapy, so that's the answer to some of the questions. So patients can be on an injectable like Ajovy, for instance, and use rimagepant for acute particularly if the triptans are contraindicated. Rimagepant can be used for prevention and as acute, so preventative every other day. Then on their off day, if they get a migraine, yes, they can take an extra dose. Yes, atogepant and rimagepant can be used conjunctively as well, slightly different modes of action, and it's particularly good for patients with the medication overuse, to try to get them off the reliance on triptans with all the with all that goes with that. So yes, I have got some patients on both. They need clear explanation about which one to take when, but otherwise there's no safety concerns with using both. Okay, next slide. This is our Northants migraine pathway. I spent some time last year with Dr. Finley and others trying to get the pathway clarified with the new treatments that have come along. I have to say the NICE guidelines haven't been updated since 2012, so they don't serve our patients very well. The 3 prevents before taking a GPANT, for instance. Most countries in Europe and America have given up on that that pathway, but we're still bound by it in the UK. So that is how it stands at the moment. So considering rimagepant, if 2 triptans have failed, differences between episodic management and chronic management. Still, the Botox and the self-injects are in secondary care, with rimagepant and atogepant being more commonly used in primary care, and I think that will increase in future. Those are the injectables on the right. Impossible to select which one is going to work best for which patient, and sometimes we swap therapy, but I've got many patients who are very stable using a monthly injectable. Okay, next slide. A bit of price comparison. Still, the license for Botox is for chronic migraine only, but off high costs now. Intervention is every 12 weeks. The others are expensive medications, but you have to consider the cost saving of no A&E admission, attendance, MRI scans, all of that comes into the mix. So yeah, next slide. Those are my checklists that I do for Equipta and Rimagipant if I'm initiating treatment. So they've been put on the pathway for GPs to use. Okay, next slide. There's a couple of case studies if you're interested. These are both actually Atogepant patients, but it just shows that these new treatments have been beneficial. So first patient, a male, I've been seeing him since October 2012. He'd already been to a private consultant thinking he had a brain tumour, but that was his diagnosis: persistent headache with a migraine variant. Probably there was medication overuse in there. All investigations normal, as per usual with migraine. And you know, I went on a journey with him. He has over the years become more chronic, and between 2012 and 2014 gradually his life became unbearable, and he was off work at that time. So next slide. So that was his history, drug history, the usual amitriptyline, topiramate, pregabalin. We did an indomethacin trial as well for sometimes it's worth a try, sometimes it works. He had Botox for a while, but found the effect didn't last very long if he had any relief at all, but always a constant headache, just on a lower pain scale. I'm not sure who added in the sumatriptan, but that was added over time as well. Candesartin, and then he had several hospital admissions with some change of symptoms, course of prednisolone, tried flunarizine. Then we had Emgality, which is the galcanezumab, on a free of charge. He was keen to try it, which he did. He hated it. He didn't respond at all. Found it made him the head pain, the daily head pain increase. Resumed Botox. Tried Aimovig, and another injectable. Didn't really do anything. So when Atogepant came along, again, I had a free of charge from AbbVie. He asked if he could try it, and I agreed, not expecting anything amazing. And when I did his follow-up, he was delighted that he said, I can live with a 3 out of 10 headache, when it had been 7, 8 out of 10 day in, day out before. And I've done further follow-up with him since then, and he's almost headache free. He won't admit that he's totally headache free, but he's talking about 1 out of 10. So after all that journey, atogepant proved to be effective for him, and yeah, so he is a success story for atogepant. Next slide. So next patient, typical 49-year-old female. She was medically retired, had quite a high stress job, bank manager, although she'd suffered with migraine since puberty. Also has chronic neck pain. She's got hyperflexibility syndrome, connective tissue disorder. We could say she's been one of those sort of heart sink patients that you just think nothing is going to help. Diagnosis of chronic migraine from 2020. Tried all the usual preventatives, which were either not tolerated or ineffective. She categorically refused to have Botox, didn't feel that it was, she felt that she would have anaphylaxis, and then we offered her self-inject when they were available. She refused, fearing side effects. The infusion, which is the eptinezumab, but she didn't really like that very much. And then we moved on to atogepant. Okay, next slide. So that's her treatment history. And to my surprise, she's actually functioning very well on atogepant. The only side effect she reports is that she has more vivid dreams, but she likes it. Migraines are more manageable, and particularly the menstrual migraine. So another success for atogepant, somebody I used to hear from almost every week to annually now. Okay, is that the last slide? Oh yeah, yeah. So summary: the new oral gepants, generally safe and well tolerated. Will GPs be initiating the oral gepants under advice and guidance from secondary care? Probably yes. There's already some studies starting with that pathway in mind. And that's all I've got to say, really. There is a feedback thing at the bottom, if you wouldn't mind giving that. It's Pui's chasing that, so if you wouldn't mind just giving some feedback, that would be good. And any questions?
Yeah, there's a couple of them. Angela, if you click on the Q&A button,
Yeah.
It'll bring up all of the posts that have been made during the session.
Yeah.
And you should be able to see all the questions, or alternatively, I could just read them out for you.
Yeah, okay. So I've got what age can atogepant be taken? I think the license is 18, although I have heard from Great Ormond Street that there are trials for under 18. Yeah, so but it would be off license and probably specialist initiation with consultation with AbbVie ahead of. Yes, I can share the slide. I'm happy, or if Mel would share the slides, that's fine.
Yeah, I've got them, so that's no problem. We'll take care of that and share them afterwards.
Everyone wants the slides, yeah.
Yeah.
All presentations. Okay, somebody's saying Amy White is taking atogepant, finding it very effective. That's nice to know. Do we have to refer patients for specialist recommendation? We had discussions about advice and guidance when we were doing the pathway, and I think that is going to happen. I haven't got any time built into my schedule. I'm paid for 24 hours a week, and I have 5 clinics in those 3 days. But it would be good to have advice and guidance rather than referring patients waiting for the consultation and then having to wait again, depending on whether they land with me or one of the consultants to before they get their treatment. I have heard some patients have had atogepant direct from their GP, and rimagepant doesn't need specialist recommendation for episodic. Still, for alternate days, I think really depending on the practice. So I get some letters back saying, no, we're not prescribing that. For prevent, that sits with you. In secondary care, some patients, even if I have recommended it, they're only given two tablets per prescription, which is not always helpful. But I think with more knowledge from the GPs about the medications, how safe they are, really there's no reason for specialist recommendation. But I think it will be going, maybe have to go back to NPAG if there's going to be any change. But I think that is what we're heading towards. Yes, so the rimagepant every other day prevent. Yes, you can take it on the off day. What the Americans tell us is that if you start patients on rimagepant, they'll start taking it every day, and by the end of the year, they're rarely using it because they trust that it's going to alleviate the migraine symptoms. So it can be a good migraine preventer and used when patients are having a flare up. And migraine tends to go like that. You can have a good couple of months and then have a flare up, and you can take the tablets according to need rather than taking daily because they've been prescribed daily. So that is the beauty of rimagepant. So headache. talk about effectiveness being defined as % reduction in headache days. So you know, there are different scoring tools. There's something called HIT6. Sometimes it's not always about headache days. Sometimes, you know, if I have patients who say the brain fog has cleared, I can manage the pain with, you know, whatever. British Association Study of Headache, BASH, have got a diary that is available. There's a link on their website. You can join BASH. It's a very good resource for headache information. But the Migraine Trust as well has got good information. National Migraine Centre now, another charity. Lots of links to information and recording tools. Okay, so I think that's, I'm going to stop now, and thank you, everyone.
Brilliant, thank you so much. And what we're going to suggest, just to let you know, I will be sharing the slides afterwards to all those people who left comments.
Yep.
Also, I'll send out a mailer a little bit later that will have the QR code and the feedback form.
Thank you.
That'll go to everybody who's attended. So if you please could fill that in, that would be very,
Okay.
very appreciated.
and to Pui, please. Yeah, if you don't mind.
Yeah.
Yeah. Okay.
Absolutely no problem at all.
All right. Thank you.
Brilliant.
Then.
Thank you very
Thanks.
much.
All right. Bye. Bye.
Shall I suggest, just before we carry on with the presentations, I see Ellen is here. Would it be all right if we grabbed a short comfort break? I've had a couple of people ask about that. So if we just say it's 15:08 now, if we could say get back for quarter past 3, and then we'll kick off the final session of the day. So yeah, we'll take a short 7-minute break. Well, hello everybody. Coming up for 3:15, so heading into the final session of today's PLT. Speaker that we have now is Ellen Nicholson, who joined NHS Resolution in April 2020 as the National Safety and Learning Lead for General Practice. This role works collaboratively with general practice and the ICBs in integrated care systems in England to maximise learning from claims, reduce any future harm and support early and effective engagement within primary care. Today's session is going to provide an introduction to NHS Resolution, look at claims profile in general practice and discuss safety in primary care, looking at triangulating data, documentation and duty of candour. So hopefully Ellen's back and ready for... Hello, Ellen.
Hi, helps if I take my microphone off, doesn't it?
Yeah. Are you all right with sharing in Teams?
Well, let's see how we go.
Fantastic. Yeah, that
So,
looks like it's working.
hopefully.
Fantastic, thanks.
Do you want me to make a start or do you want me to wait another minute?
No, I think we're good to go.
Okay. So hello everybody. As you've just heard, my name is Ellen Nicholson. I'm the National Safety and Learning Lead at NHS Resolution. I will say it up front, many clinicians still haven't heard of NHS Resolution, so I'm going to talk a little bit about who the organisation actually are, where we sit within the health system as well. So we've already heard a little bit about kind of the session overview. Basically, as I said, it's an introduction to NHS Resolution and talking about kind of general practice indemnity, a little bit of scene setting about the type of things that we see, and then how we can utilise kind of learning from claims to support patients and practitioner safety in general practice. I'm going to touch on a little bit of clinical negligence, talking about documentation, duty of candour. Please do put kind of questions in the chat if you've got any questions. I'm a registered nurse by background, a nurse practitioner, a non-medical prescriber. I don't have a legal background. That said, I'll talk a little bit about the legal teams that we have within NHS Resolution. And after 5 years, you do tend to pick up a little bit of that kind of language as well. So please stop me if I say something that somebody doesn't actually understand or put a question in the chat. So NHS Resolution, we used to be known as the NHS Litigation Authority. That's maybe the name that some of you know. We changed our name, I think, round about back in 2015, 2017 to NHS Resolution because it was felt it was more approachable and that actually we were looking to resolve claims within the NHS. We are an arm's length body of the Department of Health and Social Care, so we sit directly under them. Having said that, though, we work very closely with kind of other health partners, so kind of with CQC, with HSIB, with Health Watch, you know, the Care Quality Commission, and we work alongside kind of NHS England and the Royal Colleges as well. So we're very much integrated, but as I said, we're not necessarily known within the NHS, and which is understandable, really. People don't necessarily want to think about kind of claims happening to them in practice. Like any NHS organisation, we have a number of priorities and we're just refreshing our strategy at the moment. So this is our kind of 22 to 25 strategy you can see on the screen, but there's a new one coming out. I don't think it's going to be materially changed. There'll be a few tweaks essentially, but I imagine it's going to be fairly similar. So as an organisation, the largest part of the organisation is our claims management team. So we have around about, I think it's around about 500 people working in the organisation across England. We have offices based in London and Leeds, and our claims management teams, often these are people who have a legal background, so they have a legal degree. They may well be solicitors, but often they're non-practicing solicitors, and they've come into the kind of claims management team and they handle the legal kind of expertise. Alongside our claims management team, we have what we call panel firms, so a number of legal firms around the country who help us with our claims, and they take on the kind of responsibility should a claim come through. So we essentially kind of process and manage the claims, and they handle the kind of the legal side of it, the panel firms. They're based in regions, so there will be specific kind of panel firms that are allocated to your region within Northampton. And they're based on the NHS England kind of regions model. So, you know, for the east of England, the Midlands and East, etc. Another part of the organisation is primary care appeals. So for example, is around if there was a contractual dispute between, say, general practice and NHS England, that may well be that it's not able to be resolved at the beginning, and then it may well come through to the primary care appeals. Another kind of example might well be if there was a dispute around a community pharmacy contract, and it might well come through to us as well. The Practitioner Performance Advice Service are very much focused on the responsibility of managing the performance for doctors, dentists and pharmacists. Some of you may have heard of HPAN. They manage the kind of HPAN notifications. So it may well be that somebody has a concern around a particular kind of GP or dentist in practice, and they report that into NHS resolution. And then obviously there will be some work looking at that kind of performance, whether an action plan needs to be put in place and what concerns need to be managed. And they liaise as well with the regulators. So they'd liaise with the kind of the regulatory bodies for GMC, etc., or the Healthcare Professions Council. And then Safety and Learning is the team that I sit within, which is very much supporting kind of our claims management team and other colleagues. And we're looking at our members who are our trusts within kind of England and beneficiaries who are general practice, to help them understand kind of the claims that we see, risk profiles, particularly in trusts, and to kind of help with targeting safety and improvements and sharing learning back across the system, which is what I'm doing here today. The strategic priorities are very much around delivering fair resolution. So if an incident does happen, to a patient or a family raises an incident on behalf of the patient, you know, and harm has occurred to that patient, then obviously we're looking to deliver a fair resolution to them. We sit on quite a lot of data within NHS resolution. It's retrospective data, but that data can be used to kind of share the insights, which is what I was saying about kind of safety and learning. Understandably, we have a lot of maternity kind of data as well. It won't sort of escape you that, you know, we hear stories within the newspapers or kind of regionally about maternity outcomes and kind of poor care that's actually occurred. And there is a lot of focus within NHS resolution on our maternity claims. Because I work with general practice, tend to get less involved in that particular side of things, but we have a safety and learning team that manages maternity early notification scheme and maternity improvement schemes where they go into trusts and, you know, they're setting particular goals and key performance indicators to help improve maternity care. And then, like any organisation, it's about investing in the kind of people who are working there and systems to transform our kind of business. We're undergoing a big kind of data programme at the moment, upgrading our systems, so they're going to be fit for the kind of 21st century. I just move on to the next slide. So we're here anyway to talk about kind of general practice. So from a general practice indemnity perspective, we have a couple of schemes that are pertinent. So the CNS GP scheme, clinical negligence scheme for general practice, first came about in April 2019. Prior to that, general practice indemnified themselves through the medical defence organisations, and what was found was that actually the costs of that particular indemnity was rising, and it was becoming unaffordable for kind of GP partners and practices to actually indemnify themselves. There were conversations with the Department of Health and Social Care, or as was at that time, and now it's been taken on board as part of the kind of offer to general practice. The cost is included within the GP contract, but for kind of general practice, essentially, you don't pay for it because that cost is in the kind of GP, or it's been embedded in the GP contract. So it's been in operation for, well, it's just coming up for 6 years now. As I say, it started on the 1st of April 2019. Second to that, we have an existing liability scheme for general practice, which was launched in April 2020. And that is very, very similar to the CNS GP scheme, but it's taken on historic liabilities from a couple of kind of the medical defence organisations. So we took on historic claims from the MDD US, also from MPS as well. And those claims were transferred as a bulk across to NHS resolution. It doesn't apply to all of the medical defence organisations, just those two particular ones. And gradually over time, I would imagine that scheme will become kind of amalgamated into CNSGP, because obviously historic claims will take a little bit of time to tidy up and process, but actually they'll pass on by. And then we obviously have the clinical negligence scheme for coronavirus as well, which was launched during the pandemic, which is still running. We do have other schemes that we run for kind of hospital trusts and those type of things, but I haven't put them on this screen. I've just kind of really talked about the kind of ones that are pertinent to general practice. I just move on to the next slide. So CNSGP, what it actually covers is there's an animation that we have on our website. I'm not going to play it today, partly due to time, but also when I was reviewing this, I was thinking actually it's a little bit out of date. It's talking still about kind of what we actually put in place back in 2019. And I think there's a need to actually refresh. But I put some links on here, which will take you to the kind of general practice indemnity pages and the claims management team, should you kind of want to look at some of the resources, but also the beneficiary charter as well. So because general practice don't actually pay the upfront cost for kind of CNSGP, we call you beneficiaries rather than members. And the clinical negligence scheme for general practice, it's free to everyone within general practice. You know, it doesn't matter whether you're a receptionist, a GP partner, a locum coming into work in general practice, everybody is covered by CNSGP. It's important, however, to remember it doesn't cover everything. This is literally around clinical negligence. So we don't kind of cover private work, we don't cover inquests. So if you're doing private work or anything like that, it's always important to have kind of, you know, cover with your kind of MDO. So this is additional to that MDO cover that you should have as well. I move on to the next slide. So this is just a kind of snapshot. Every year, NHS resolution is they have to put a report before Parliament. So our annual report is just being produced at the moment for the kind of 24-25 year. So this is the kind of latest data that we have, is still kind of last year's data. And you can see how many kind of incidents happen that were reported. We're talking millions of incidents are reported to the National Reporting System each year. You can see how that's broken down, and that's data that we've collected from NHS Digital, as was. And then you can see how many have come across and become claims. Now, obviously, we don't know that an incident was reported of those 2 million, became a complaint, became a claim. It may well be that actually it wasn't reported as an incident, but actually came straight to NHS resolution as a claim, or it may be that it went through that particular process. But it just breaks down a little bit about how many incidents happen within the NHS, how many complaints we see across the NHS, and how many claims we actually have. And that's why we've got the picture of the iceberg, really. We are literally just the tip of the iceberg, the bit, you know, at the far end of the process that people see in general practice and NHS. But if I just go on to this one. So this just kind of shows the data that we see across all of the schemes now. So I'm including trusts as well as kind of the general practice claims. Back in 2014, you can see it was just NHS trust claims that came through. And then obviously as CNSGP and ELSGP started in 2019 and 2020, you can see the numbers going up there. And as I said earlier, with ELSGP, it was a tranche of cases that was actually transferred from the medical defence organisations across. So it wasn't that suddenly 3,292 cases came across as new cases from ELSGP, but they were historic cases that were ongoing that came across to us. But you can see that actually in 23-24 general practice claims, it was around about 2,800 claims that came through. Now, not all of those will actually become proven claims. These are incidents that have happened, that have come to NHS resolution, that are going to be investigated by our claims handlers. and also our panel firms. And it may well be that actually there is no case to answer, but it may well be that actually there is a case to progress. If I move on to the next slide. And this is then looking at kind of the number of clinical claims, again, 23, 24, and a little bit of a breakdown for you so that you can see what kind of claims that we actually have coming through. You won't be able to see general practice on this slide. General practice sits in that kind of 32.9% of the claims, purely because there's a small percentage of general practice claims that are actually coming through. You can see that the kind of the higher incidences are the emergency medicine, so we're talking ED departments, and as I said earlier, kind of maternity claims as well, obstetrics, early notifications. We also see a number of kind of general surgery and orthopedic surgery claims coming through. And you can see them broken down there by percentage. But as I said, you know, kind of general practice, we saw around about 2,800 claims come through to NHS resolution. I think over the totality since the scheme started, which, as I said, is just coming up 6 years, I think it's around about 8,000 claims that we've actually seen come from general practice settings to NHS resolution. And this is just breaking down by the kind of top causes of value as well. So within general practice, what we tend to see is kind of the failure delay referring to hospital. And that may well be that actually we've forgotten to kind of fill in a referral form, or there's been a delay in transport, or it's been kind of involved with the kind of paramedics and ambulances. A missed delayed diagnosis, so failure delay in diagnosis, failure delay in treatment, maybe a particular treatment hasn't been authorised. Medication errors as well, focus in there as well. So those are the type of things that we tend to see. I don't think really any of them are particular surprises for those of you working in general practice. There's been a number of articles produced by our kind of legal teams over the years. There's been kind of newsletters that have gone out from those particular teams to practices via the kind of medical defence organisations talking about these type of themes. So they're consistent themes that we see within general practice. I just go on a little bit. So when we first took over the CNSGP, or when it first started in 2019, the Department of Health wanted to actually have an overview of the type of claims that were being seen within NHS resolution. So I looked at the claims for that first year of the scheme, which was 2019 to 2020. Obviously, it was very, very small numbers in 2019, 2020, partly due to the pandemic, if you think about that coming in at the end of that year, but also because of awareness as well. It took a little bit of time for people to realise that we'd changed from the Medical Defence Organisation to this slightly new scheme, and knowing how to access it, and just knowledge of the scheme, really. But as I just said earlier, you know, the type of things that we found within those 401 claims that came in that first year were the themes that we expected to see. So the missed delayed diagnosis, the medication errors, delays in care, as I said, and problems with kind of communication. I would say that overall, the majority of claims, it was 43.5% related to a delay in diagnosis. And it was around about kind of 18% that related to the medication errors that we actually saw as well, just to give you an idea. And part of this was, as I say, it was good for the Department of Health to actually have an idea of the type of claims that they would be seeing in the CNSGP scheme. Since that time, it's remained essentially similar. We're still seeing medication errors coming through. We're still seeing missed delayed diagnosis claims coming through. So it was reassuring in a way that there weren't any big surprises in there. And when we broke those kind of 401 claims down, you can see that we looked at kind of various clinical conditions such as cancer, sepsis was in there. We had kind of missed delayed diagnosis of pulmonary embolism, appendicitis, cauda equina as well. So somebody would present with back pain and hadn't been diagnosed at that point with cauda equina, or they hadn't been safety netted sufficiently to actually recognise that it might be cauda equina. And again, those type of themes that we're seeing coming through are consistent. on the back of this particular report and the fact that cancer came out as the top theme in that first year, we looked at the CNS GP data and the ELS GP data over the next few years. And we have a misdelayed diagnosis report in cancer pertinent to general practice that was supposed to be released last year, but like all kind of NHS reports, tends to have a little bit of slippage in time. So that should be released in May this year. And we are intending to put on a national webinar for anybody who's interested in looking at those particular themes. We've been talking to kind of various experts within cancer care, as well as the Royal Colleges as well, looking at those particular themes and trends. And as I say, it should be, the date now is that it will be released in May, but I don't know whether it will be the beginning of May or the end of May. But we can let you know and pass on the link for the webinar when we actually host that. And again, looking at those CNS GP notification causes, as I said, you know, it was that delay, failure in diagnosis and prescription error in those 401 claims in that first year that came out. And you can see that on the screen. So this is taken on the back of the earlier slide. So as I said, it was around about 18% of kind of medication errors, prescription errors that came through. Very small number out of the kind of 401 cases. And we looked a little bit further at those particular medication errors across our schemes of general practice schemes with a little bit more data, and what type of things were we actually seeing. And you can see kind of antimicrobials were an issue, kind of the heparins and anticoagulants were coming through. Vaccinations too. So if you think about a general practice fridge, you have a number of vaccinations in those fridges for kind of childhood immunisation programmes. If you think about the packaging, sometimes the packaging is very, very similar. And it, you know, if you're in a hurry, it may well be that actually somebody takes the wrong vaccination out of the fridge, thinking it's a different one. And so those type of medication errors can happen. We had opioids in there as well, narcotics and sedatives as well in those medication errors. On the back of that, we've produced a kind of what we call a did you know leaflet, so to speak, talking a little bit more about kind of general practice medication errors. And I've put the link in this particular slide. And that was part of a series of medication errors leaflets that we did at that time. And there's some links at the end as well, if anybody's interested. I also know that when I was talking about coming to speak to the Northampton PLT, there was actually some interest in doing some more kind of in-depth work looking at the medication errors, and that's certainly something that we can do. This is just an overview today. As well as the CNS GP report looking at kind of the general practice claims, we also have one that looks specifically at kind of patients who attended emergency departments, and we called that particular series the kind of high value and fatality related claims. And unsurprisingly, there's a lot of correlation between kind of general practice, the type of things we see in general practice, and the type of things that we see in kind of emergency departments. So again, I've put this slide here and we've included the link to that particular report if anybody's interested. But again, it's the similar themes around the kind of diagnostic error, missing the signs of deterioration, the failure to diagnose, and the failure to recognise the significance of repeat attendance. I think that's something that we found in both reports. The patients who are attending their kind of general practice and then maybe being seen in kind of out of hour settings, being seen in the ED department, how are we actually kind of managing those patients? How are we following up? Are we actually thinking about what might actually be their kind of specific issue, and needing to kind of call them in for a consultation and have a discussion with them? So those particular patients, again, it's not a surprise to general practice, but those particular patients are a challenge to manage. And it's how we identify them and how we manage them in practice. Unsurprisingly as well, in both reports, we found that communication was an issue as well between primary and secondary care. And we know that from practice as well. So I've spent a couple of decades working in general practice. We know that sometimes referral letters don't come back to us. We know there's transcribing errors between particular medications being put onto the system. Sometimes we can't get hold of the people in secondary care, or secondary care can't get hold of general practice as well. Advice and guidance, you know, it's not standardised across the country. There are kind of, you know, pockets which are excellent, pockets which obviously could do with a little bit of help sometimes. So, you know, these communication issues aren't new to general practice or secondary care. It's just how we approach them. And this is just going through a little bit of the kind of law and around what is actually medical negligence. As I said, I'm not a legal person, but this is taken from kind of our legal frameworks that we use within NHS resolution. So basically, a health practitioner must have acted in a way that fell short of acceptable professional standards, and that's known as a breach of duty. For somebody to have that decided, it would have to be a health practitioner of the same discipline. So the legal team, if they have received a claim through around a particular case, they will reach out to what they call experts, professional experts that they have in a particular field. So, for example, if a GP was alleged to have been negligent, it would be a GP expert who must comment on that particular care. And there's a Boland versus Priam Hospital Management Committee case on the screen there you can have a look at. In the same way, you know, if it was a nurse practitioner, it would be a nurse practitioner who would be commenting on that particular practice. So it's judged, the conduct is judged according to the standard of reasonable care that's been taken. Has that practitioner got that particular skill, or have they fallen short in their standards? As I say, claims is very much a legal process. I've talked a little bit there about the breach of duty and the standard of care. Causation is, you know, what's caused the harm, what's contributed to that particular injury or harm. If that kind of breach of duty, that standard of care has fallen below that particular threshold, it may well be that kind of NHS resolution panel firms may actually say that actually we need to admit liability. That may or may not be the case. And if a claim does come through to us, then obviously we will kind of, you know, guide you. Our panel firms will guide you. We are in a litigious culture. You know, when we look at the figures for NHS resolution over the last year, I think there was a newspaper article recently, and it was around about just under £3 billion that was paid out on claims in a particularly, I think, last year, which is a huge amount of money. That's kind of £3 billion from the NHS budget. It's not money that, you know, is set aside for claims. It comes from that kind of total pot. So obviously, if we can impact on patient safety and we can impact on reducing claims, it may well be that actually we'll have more money within the NHS to actually spend on other services. So when does claim actually come through? There are limitations on this. So normally it's within 3 years of the date of an incident. So an incident happens in primary care or secondary care, and then it's 3 years from that date. That doesn't apply to children. It's 3 years from their 18th birthday, which would take them up to kind of 21. So obviously, if you have a maternal injury, a birth injury, that's going to carry through. If somebody has no mental capacity, there's no limitation. Or it's 3 years from the date of knowledge that something has occurred and you recognise that harm has occurred. And this is just looking at a claims life cycle, the kind of type of thing that we typically see. And there is a time lag. As I said, you know, NHS resolution, our data is retrospective. So an incident could have happened years before, 2, 3, 4 years before. Nobody wants to make a mistake in practice, but sometimes, you know, things do happen. Systems let people down, but there's that kind of professional responsibility and accountability for kind of actions that do happen in practice. So if an incident does happen, it's very much on us with that duty of candour to be open and transparent about what's gone wrong, to actually contact the patient, contact the family if that's the case, and just talk about what's gone wrong and have that conversation with them. It may well be that actually a complaint comes into the practice, and you may not have realised that an incident has happened, but a patient or their family might decide to complain. It's always worth, our legal teams say, it's always worth not kind of putting your head in the sand or pretending something hasn't happened. It's always worth being open, transparent, having that discussion with the patients and their families, and with your colleagues as well, talking about what's gone wrong or what you think has gone wrong, and starting an investigation. So you're kind of learning from that harm that's happened. It may well be that when you've had that conversation with the patient and their family, actually it doesn't go any further. They're kind of happy with the explanation you've come up with in practice. You've talked it through, and they may decide not to complain. Or it may be that actually a complaint is forthcoming. It may be that there isn't a complaint at all, actually, and the first notification that the practice has that something has happened is that the patient or their family could go to a claimant solicitor, and then there will be a letter that comes to the practice. It's called a letter of notification, usually looking to look at the patient's medical records. And that really is the point when NHS resolution should be involved. And if an incident happens and you know that harm has happened to the patient, it's always worth getting in touch with NHS resolution at that point. But definitely, if a letter of notification comes through to the practice, please get in touch with NHS resolution. We have kind of a telephone number, we have an email address, and our claims handlers will talk you through what's needed next as well. And you can see from that kind of letter of notification, it may go on to a letter of claim. There may well be negotiations between kind of different parties, so between the claimant solicitors for the patient or the family and the NHS solicitors, our panel firms within NHS resolution. And they will talk about, you know, kind of how that process is going to be managed. Letters of response go out. Is it going to be defended, that particular claim? Is it not going to be defended? Has liability been admitted as well? Very few of the claims that come through to NHS resolution actually go to trial, which is a good thing. Most of them are settled in their out-of-court settlements. Going to trial is very stressful for patients. It's very stressful for families, and it's very stressful for kind of the workforce as well. So anybody who's involved in that kind of particular claim. And it's also very costly as well. So it's a good thing that very few actually go to trial, but obviously sometimes it does happen. And if it does happen, then obviously any clinician would be supported through that process from NHS resolution. And there's also a significant time lag in these claims. So an incident could happen 2, 3, 4 years ago, and then you may not actually receive a claim for it until 3 years later, which is where kind of documentation is so important. If it is up-to-date documentation that you've actually written at that time of when you saw the patient, and you've got that full history in there, it's particularly helpful. But you know, if your documentation is kind of slightly sketchier, it may well be that actually the NHS can't defend that particular claim. Why do people claim? So there's a number of reasons why they claim. Often it's around kind of wanting to. Sometimes patients and their families consider that NHS staff, their responses were generally inadequate. We produced a report looking at kind of 10,000 former claimants they were approached by NHS resolution to ask them why they actually had made a claim. So there were in-depth interviews. The report is a number of years old now. I think it was written back in 2018. And obviously, if you want to, you can kind of scan the code and read that report. But the majority of those 10,000 claimants said that they weren't satisfied with the NHS complaints handling process. And sometimes there was a kind of external motivation to a claim, was a suggestion from NHS staff saying, well, actually, you know, if that had happened to me, I would make a claim, or you should make a claim to the NHS. So I think that's quite interesting why that actually does happen. But obviously, the chief executive of NHS resolution, Helen Vernon, would say that, you know, if harm has happened, you know, we should always say sorry. We should always be open and transparent in that duty of candour to our patients. And, you know, if harm has happened to the patient, it's right and proper. Actually, it should be investigated and may well come through to a claim. So from the point of view of the record keeping, I mean, there's a number of records that actually we have, you know, available to us and kind of evidence. Obviously, you've still got kind of Lloyd George notes hanging around in general practice, used less now because obviously we've got electronic patient records. But there's email trails, there's meeting minutes, there's kind of drafts and final reports, there's imaging. There's lots and lots of different types of records that we actually have. And it may well be that many of these might be asked for if the claim comes through. And so it's really, really important that we have contemporaneous notes, that we, ensure that our kind of documentation is kind of clear, complete, accurate, up to date. If you discover that you've forgotten to put something in there, or something comes along after you've actually completed that documentation, please don't go back and amend a document. Just add an extra note. It should be completed understandably at the time or soon after seeing that particular patient. All your kind of history taking, and that should be kind of included in the documentation, whether it's normal, abnormal. And we're not actually, wanting to see kind of essay notes in documentation, but it's that kind of clear, concise history that somebody could follow if they were coming to that patient and that documentation after you, and wanting to know what care had actually been given. You should particularly note kind of recommendations for future or ongoing care. And I would particularly stress there around safety netting. How do you safety net? Are you precise in your safety netting? So, for example, if a patient had a chest infection, you've given them antibiotics and you said to them, if this is no better, come back. Is that actually sufficient safety netting? Or do you need to be clearer and say, better within 24 hours, 48 hours, this is what you need to do. These are the side effects of the medication. If you experience these, please come back and see me. So those type of kind of more precise safety netting decisions need to be documented. Writing safety netting kind of, in your notes doesn't necessarily say what you've actually done or said to that patient, and that could be disputed. So think about how you actually word that. And putting down any concerns or preferences expressed by the patient during that consultation may well be relevant as well. What I would also say is sometimes, some practices actually follow up. They send kind of the patient leaflet across to the patient afterwards, after the consultation. And we know from kind of research that actually patients, when they're having a consultation with a healthcare professional, GP, nurse, allied health professional, they don't necessarily remember all the details in that consultation. So actually sending kind of a patient information leaflet afterwards may well be a good idea. This is just looking at how we kind of triangulate data. So obviously, with claims, we're looking at patient safety events. So if an incident has happened, we're looking at complaints, and we're looking at kind of any safety data as well. There's a big push now within the NHS around patient safety. The patient safety incident response framework is very much in trusts now. It's mandated there. And since September 2024, had to think which year we're in, we've had a primary care patient safety strategy as well, and that was launched by NHS England. There are some practices that are actually using PSERF models, and so there's some kind of pilot schemes going on in primary care, and some kind of primary care practices are taking on the kind of patient safety strategy as well. It's not clear at the moment where the patient safety role is actually going to sit within primary care. Is it going to sit within the primary care networks, or is there going to be kind of that responsibility within each practice? We have kind of the patient safety strategies within the ICBs. So I think we're still working through that. And I think it's particularly pertinent at the moment. Dr. Penny Dash, who's going to be the new chair of kind of NHS England, she delivered a report on CQC last year, and as part of that she's gone into a second report where she's looking at kind of patient safety sphere at the moment, looking at a number of organisations such as NHS Resolution, HSIB, and CQC, and how we work together is the duplication across the system as well. So that report was due out in January, again with slippage. It's due to be out within the next couple of weeks, I believe. So it may well herald some changes within the kind of patient safety sphere, and there may be some recommendations in there. I think, when we look across the NHS as a whole, and you look at NHS England and the changes that are happening there, we're in a time of change within the NHS, and it may well look very different in a month, kind of a year's time. So I think we have to think about that. I digress slightly anyway. I was talking about triangulation of claims and how we pull that kind of data together. So it's really important to kind of look at all those different kind of sources of data, so that actually we can work out kind of the themes within practice, think about kind of are the regular themes that we're seeing in our kind of incident reporting in practice, or and what can we do? Can we put an action plan in place to think about kind of changing the way that we practice, so that we can reduce these particular themes as well? And I think you can draw that out from the kind of claims data, kind of the incident data and complaints data. And this is just looking at how we might possibly learn from litigation claims. So, you know, if we're kind of thinking about that kind of incident happening and the immediate learning, we're very much looking around kind of just cultures, kind of fair cultures, and learning from harm rather than defensive practice. As I said, nobody intends to make mistakes. It's very, very rare that you have that kind of malintent. But mistakes do happen. You know, we're talking about human factors, we're talking about dealing with humans, and mistakes do happen. And so following kind of the patient safety incident response framework type process, when we recognise harm occurs, as I said, you know, saying sorry and involving our families in that kind of that immediate and longer term response, you know, that duty of candour and openness and transparency, is really, really important. But it's not just with the patients and their families, it's also thinking about the impact on staff as well. You know, as I said, it's an incredibly stressful experience for the workforce as much as it is for patients and their families as well. And I talked a little bit kind of on that claims timeline as well, that it may well go to mediation, it may well go to a court process, and there may well be damages paid out by the NHS and NHS resolution to a particular patient or their family. But what do we actually learn from that kind of incident? You know, if we've triangulated it with existing data, it may well be that actually we can put some quality improvement projects in place to actually improve things. It may well be that we could actually put some case studies together. Generally, you know, obviously they'd need to be anonymised rather than actual patients, or pseudonymized, so that we can't identify patients. But actually case studies are really, really valuable. You know, learning tools to actually make people think about how they can improve things. And obviously it's a continual learning process. You know, we're looking to reduce harm, and we're looking to reduce claims and complaints as well, within the NHS and within practices. What patients expect. So what we find with our patients when we do see them within NHS resolution is they really wanted to kind of be listened to. They wanted somebody to understand and to hear what they were actually saying. They wanted an apology, and saying sorry is never the wrong thing to do. They wanted to receive an answer, but often as well, they wanted to feel that because they'd been heard and listened to, that actually their particular incident wouldn't be an incident for somebody else. So they wanted learning to happen as well. And for our workforce as well, you know, as I said, it's a particularly kind of stressful environment if a claim or a complaint actually does happen. And they want to have kind of that understanding and support and compassion. They also, you know, you want to learn from harm, and, you know, how to prevent it in the future. And many would like the opportunity to actually say sorry to that patient. It is a difficult conversation, without a doubt, but actually having those difficult conversations is the right thing to do. And it's that kind of open, transparent, duty of candour type process. And then signposting where appropriate in both cases, you know, where is it appropriate to signpost to? Is it appropriate to kind of signpost your patients to the asthma, kind of where they look at obviously helping people kind of process claims? Is it appropriate to signpost a staff member to counselling, or kind of to their union to actually have some support and help there as well? So it's really thinking about that as well. I'm going to try and play this animation for you. So NHS resolution have put together kind of this, well, it's a relatively short animation, talking about kind of professional and statutory duty of candour. And as I said, saying sorry is always the right thing to do. It's not an admission of liability, but it really needs that kind of compassion. So if I try and see if I can get this to work. Thought it might do that. It's always a challenge when you're trying to make links work.
Hi, Ellen. Just a quick one. If you want to get the sound to come out, you just need to click on the share button. There's a little slider by the side of it that says include sound.
Is that it? Maybe I won't be playing that.
It's where you would have shared your screen from inside Microsoft Teams.
Well, maybe I won't play that. Maybe I'll leave that for other people to kind of look at as well and see if I can get myself back. Nope. Get myself. Oh, I've lost my slides now, haven't I? Totally. Just trying to see where we are. I'm sorry, everybody. I'm clearly not very good at this. If I stop sharing for a moment, then I'm going to go back and share again and find them again and not play that. I would recommend, actually, if you do have a chance to go and listen to the kind of duty of candor. It's about 8 minutes long, but it's actually quite a it's quite a good video to look at. I've got this screen up again, haven't I? I've totally lost my own slides now. Is it possible to share my slides for me, just to find them again?
I can do, but all I've got is a PDF version of them.
That's fine. The PDF version is fine. I'll just kind of get you to kind of scroll on. If you could go to that kind of duty of candor one, because we're very close to the end anyway.
No problem at all.
I'm very sorry about that.
Just had the biggest hailstorm I've seen in ages hit over here, and I'm in a polycarb roof. So if you hear noise in the background, very sorry.
Well, it's that spring weather, isn't it? So anyway, as I say, that's the duty of candor, and I clearly need to kind of up my IT skills. It has a QR code if anybody wants to watch it as well, but I think it's really worth watching because it actually identifies the kind of professional and statutory duty of candor, and sets it out nicely. And it's a really nice learning tool for kind of practices as well. If we just go to the next slide, if that's all right. Yeah, so also alongside what I've been talking about with the kind of duty of candor, NHS Resolution have produced this particular resource. We did a report called Being Fair a number of years ago, and we've updated that, Being Fair too. I'm just talking about kind of just learning cultures within practice as well, so that we have that psychological safety within our practices, within our workplaces, to actually have that kind of open learning environment and not that defensive practice as well. So it kind of cites recent reports such as Messenger. It talks kind of about workforce issues such as incivility, bullying, harassment, and those type of pervasive behaviours in kind of healthcare that we see. And I think it's a really important kind of resource that actually you can have a look at, and think about how it could be incorporated into your particular work environment. Just go on to the final slide, so the next slide anyway. I think it's really important kind of we as practitioners that we have that kind of psychological safety within our workplaces. You know, do we feel included? Do we feel able to share? Do we feel safe to kind of learn, to kind of open up and talk about kind of various incidents that might happen or particular cases that you're dealing with in practice? Are we happy to contribute in meetings? Is everybody equal within those meetings and able to contribute? And obviously the kind of ideal is that, are we safe to challenge as well? Are we safe to kind of ask questions and say, well, actually, I don't think that's necessarily what I would say in that particular situation or do in that situation. And I think that's really, really important when we consider kind of those kind of working environments that we have as well. And I think it, you know, having worked in general practice for a couple of decades, I think it's really important for general practice as well, because we are quite isolated as clinicians in your rooms with your consultation, seeing your patients. And I think it's really important to actually have those kind of that open, transparent conversation between practitioners and kind of work colleagues as well. If you just go on to the next couple of slides, I think I've finished the presentation. So I've got my kind of details there. the telephone number for NHS resolution is there, and obviously my email. And if you can just flick on a little bit, Craig, as well. Within the slide pack, obviously Craig's already got the slides ready to send out to you. There's the kind of thematic reports I was actually talking about. There's links in there to each of those reports as well, so you can just click on them if you're interested in having a read. And the next slide, Craig, is around kind of medication errors. As I said, you know, there's a number of medication errors across the system, and we've just identified some of them as well. And more than happy to kind of drill down and look more at medication errors in a particular group. And if you could just go on to the final slide, Craig. Like everybody else, we have feedback forms as well. So there's a smart survey link in there, and there's a QR code. And we'd really, really appreciate you sharing your thoughts. And anything else that you actually want to hear from NHS resolution, if you want to hear kind of specific case studies, case stories, as I said, kind of medication errors or anything specific. I think I finished a little bit early, but it's a whistle-stop tour essentially of NHS resolution. And I hope it's been interesting. And thank you for listening.
Thanks, Ellen. Just to let everybody know, I have in the Q&A section, I've put the link to that feedback form, so you can access it from there. There are two questions. One's from Jane. Misdiagnosis in cancer care would be interesting to see, please.
Yeah, absolutely. So as I said, you know, the CNS GP report from 2019-2020 identified the cancer, kind of misdelayed diagnosis in cancer. Literally, it's really, really interesting data that's coming through. And the report is currently with the proofreaders. So as I said, it should be published in May. And then obviously we're going to be putting on a kind of national webinar with NHS resolution colleagues, panel firms and kind of cancer care experts. And we'll definitely send that link out to everybody within primary care to kind of register as well. I'm thinking it'll probably be around the end of June. That's just because I'm slightly cautious about kind of slippage around dates of publication. But we're looking to get it in that first quarter of the new financial year. But it is really interesting. Yeah.
And final question is, contraception coils and minor surgery used to be part of day-to-day GP. Why is it not covered by the CNS GP?
CNS GP covers everything that's in the NHS contract, NHS GP contract. So if it's in the GP contract, it's covered. If it's not in the GP contract, then it's one of those things that has to actually be negotiated when they go through the kind of GP contract negotiations. So it's not the NHS resolution are deciding what's being included and what's not being included. It's basically modelled on that GP contract. So NHS care that's in that GP contract is covered by CNS GP. Having said that, I would say that, you know, healthcare is a changing environment, isn't it? And sometimes there are certain things that come through in healthcare. If you're ever uncertain, please contact us. We can have a conversation with our technical claims unit. We have a really close relationship with the Department of Health and Social Care. You know, and it may well be that actually it's something that could be included in the future. Because healthcare isn't it's not a stationary thing, it changes all the time. So, you know, if you're not sure, please contact us and we can kind of set you straight. And sometimes it's a grey area as well, you know, everything that's included in that NHS contract might well kind of have some grey areas in there as well. So it's always worth kind of clarifying if it's included. We've certainly done some work with some kind of integrated care boards where they've been wondering about how their kind of wound care pathways are incorporated into kind of the CNS GP, or where they're incorporated into CNS GP. And we've been working with them so they can understand that. So please do get in touch. And thank you. I don't know if there's any more questions.
No, that's it for now. Thank you very much.
No, you're very welcome. And I hope that's been interested.
Oh, that's really fantastic. Thank you so much, Ellen. Really appreciate it. Right. That is it for today's PLT. The next one, we're back with Countywide PLT on the 7th of May. So a couple of months break now. Basically, what's going to happen next, I will send out a mailer to everybody. We're looking to get ideas for the next batch of Countywide PLTs. So there will be a short feedback form. We're going to be really, really sneaky. So if you want a certificate, you'll need to fill in the feedback form. That's kind of the way that we get people to do these feedbacks. They're quite important for us. So watch out for that one. I'll also include the links to the other two feedback forms, the one from NHS Resolution, and then also the one from the management of migraines as well. So you'll have all of those. But thank you very much for your attendance. We tried something different with this one with the town hall Microsoft Teams. To be perfectly honest, I've just looked at the attendance report and it didn't work. So that's why I'm going to need to ask everyone to fill out the form before I send you certificates. I'm away tomorrow and Friday, so it's more than likely going to be on Monday now. But anyway, that's it from us. Thank you very much for your time, and look forward to seeing you again in May.